Now, for the next hour, it's a debate, the first in a series of debates to be held on the floor of the House with two members of Congress, Ohio's John Boehner and Vermont's Bernie Sanders. We will talk with the two members behind the idea before we show you Wednesday's debate.
The idea came from Mr. Boehner of Ohio, who is head of the Conservative Opportunities Council, and he came to me 2 weeks ago and he suggested that it might be good for the country and good for the Congress if we had a real clash of ideas and a real debate on some of the most important issues facing this country. I thought it was a great idea. I went back to the members of the Progressive Caucus. They thought it was a great idea. We're ready to go.
What are you saying about what is going on right now on the floor of the House? Are you basically saying there's not much debate going on?
Yeah, well, Jim, I'm very frustrated, and I think most members of Congress are frustrated with how little the American people really know as to what's going on in Congress, or in fact are knowledgeable about the most important issues facing this country. The corporately owned mass media, in my view, does a horrendous job. We spend more time with violence and sensationalism and 5-second sound bites rather than honest debate about the terrible crises facing this country. This country is undergoing major economic decline. Our people are becoming poorer. We're one of two nations in the industrialized world without a national health care system. We lead the world, the industrialized world, among poverty for our kids, etc., etc., etc. Where is the debate? How did this happen? Who owns America? We're not having that debate. So I think that having some people from the right and some of us who are progressives on the left really clash and talk about the future of America, talk about the problems facing this country, will give the American people an opportunity to hear serious debate, and I think that that's a real positive thing.
Tell us specifically when this will happen.
The first debate, as I understand it, will be Wednesday, November 3rd, and it will be on the single-payer health care system. Obviously, I and Jim McDermott, who will be participating in that debate, believe that the Canadian single-payer system is the most cost-effective way to provide comprehensive universal health care to all Americans. I presume, I think without fear of contradiction, that our conservative Republican friends will disagree, and there will be then a vigorous debate on the enormously important issue of national health care in this country.
And the debate will take place within the format of special orders?
Yeah, what we're going to do, and I think it's the best thing to do, is to, in a sense, do it informally. All that has to happen is a member request an hour, and then that member then will give it over to a moderator who will conduct the debate in an agreed-upon format with certain time for each participant.
You, of course, are the only independent in the U.S. Congress.
And let me tell you something. The longer I'm here, the more and more proud I am of my state and myself for that achievement. Yes, I am the only independent in the House.
And you've lined up with John Boehner, who some would describe as fairly conservative.
John is a very conservative Republican. That's right.
Another part of the equation over here, the Democratic leadership has been talking about what they are saying is Oxford-style debate. What's your reaction to that?
I don't think it makes a damn bit of difference whatever it is. They've been talking about it, and that's what goes on here for years. People talk about it. It's not that complicated. John proposed an approach which I think is sensible. It's fair. You give proponents a certain amount of time, people who are in opposition a certain amount of time, and you have the debate. Then these guys have been talking about this forever, and I think what I'm proud of is that John and I are moving this thing along a lot more rapidly than they were thinking about.
Would you see yourself being able to participate in what they come up with later?
Well, I'm not quite sure that the Democratic leadership would want me to defend their point of view. My point of view is a bit more progressive than the Democratic leadership. But I think within the Progressive Caucus, we have a number of very, very bright people who are concerned about the major issues facing this country. We went around the room, and there'll be people pairing off on particular issues. I myself feel very strongly about the need for a single-payer Canadian-style system. Obviously, Vermont borders Canada, so that's an issue that I have familiarity with. Jim McDermott, of course, is the author of the major single-payer bill in the House, and Jim is a physician, very knowledgeable about the issue. So I think we'll present our case well, and I'm sure the conservatives will do their best as well.
Well, there's been a great deal of surprise because most people wouldn't see Bernie Sanders and I coming to an agreement on anything. And so there's been your typical harassment by some members in a friendly way. But most people have been very supportive of the idea that there's been some concern over special orders that go on after regular session is over, that maybe they should be limited. Others want to argue that we should keep them. But what we want to do is to make special orders more meaningful. And that we think that bringing the debates to the to the House floor can help do that.
The moderator would be another member of Congress?
There would be an agreement between their group and ours as to who the moderator would be and who the timekeeper would be. But we have to do it within the structure of the current special orders. And so that time is allotted to a member. And that member, in effect, would have to be the moderator and yield time to each side and organize the debate.
Are we likely to see many members sitting in the chairs watching the debate?
I'm not sure that at first we're going to see a lot of people on the House floor during these. But we believe if they're successful, if they're done right, and if we have the right issues and the right members involved, that over the next few months that these debates can grow and become more of an event, hopefully on a weekly basis here in Congress.
And one last question. It's no secret that the Democratic leadership is talking about what they're calling Oxford-style debates on the floor of the House, possibly. What is your reaction, and how does this fit into that?
Well, we looked at the possibility of other debate formats. The Lincoln-Douglas format is pretty well structured with a limited number of people on each side, and we think that within an hour you can get to the heart of a question. With Oxford-style debates, anybody sitting in the room is entitled to involve themselves in the debate, and we think that could get out of hand. It could be rather ruckus, and we're not sure that the question then can be fully explored, and that's the whole idea here. Can we fully explore a question in a specific amount of time? And so we settled on the Lincoln-Douglas style, and it's going to be incumbent upon us to structure questions that are narrow enough yet broad enough to be discussed in an hour period of time.
Congressman John Boehner, thank you.
Thank you.
The
Madam
gentleman
Speaker,
is recognized for 60 minutes.
Madam Speaker, during the next hour, you will witness the first Lincoln-Douglas-style debate to be held here on the House floor. This debate is sponsored by the Conservative Opportunity Society, a group of activist conservative members of the House, and the Progressive Caucus, a member organization that is dedicated to forwarding a progressive agenda. This is the first of many debates these two groups will be sponsoring. We hope these debates will provide our colleagues and the American people with an informative and critical presentation on issues of national concern. Tonight's debate will focus on the issue of health care, and the debate will be the following. And the question shall be, shall the United States adopt a single-payer, Canadian-style health care system? A single-payer health care system is defined as one in which the government pays and administers health care for all of its citizens. Speaking in favor of the resolution is Representative Jim McDermott of Washington and Representative Bernie Sanders of Vermont. Craig Thomas of Wyoming and Representative Denny Hastert of Illinois will speak against the resolution. The format provides for opening statements by each debater, a cross-examination period where each team will have a chance to ask and respond to questions, rebuttals from each team, and closing remarks. I will be the moderator for this first debate and will yield time to each of the debaters. We begin the debate with 3.5-minute opening statements from each of the participants, each of whom will speak according to the agreed-upon format. I now yield 3.5 minutes to the gentleman from Washington, Mr. McDermott, to start our debate.
Thank you, Mr. Speaker. Last week, the President came to this body and brought a health care reform proposal in which he announced that he would not sign into law any bill that did not provide universal coverage for all Americans with a very generous package. Now, single payer is the only proposal that guarantees free choice of provider and assures that you don't have to change your current health care arrangement. It breaks the link between insurance and employment. The Congress would define the benefit package and provide the financing. Doctors and hospitals, on the other hand, remain entirely in private hands. They would not be employees of the government or insurance companies. You would go to your doctor, and the state would pay your bills on your behalf, just like an insurance company does today. The difference is that universal coverage is guaranteed no matter where you live, no matter for whom you work, how much money you have. Cost control is real, and 25 cents of every dollar spent on administrative waste due to the inefficiencies and market marketing costs of private insurance companies is eliminated totally. That money is then used for health care delivery. The single payer is the cheapest form of health care reform and the plan that will leave the most money in the pockets of the citizens of this country. Every other industrialized country in the Western world has used some form of single payer to guarantee coverage and to contain costs. We should accept no less in this country. We can do anything better than any other country, and we ought to be about it. Now, what do Americans want from health care reform? They want universal coverage so they don't have to worry anymore about who's in and who's out and if the problem they have is covered. They want health care that provides free choice of provider that is affordable. They want an end to unnecessary administrative costs that are devouring our resources and can be used to deliver health care. We spend $70 billion a year in unnecessary administrative costs in our system. They want stable and comprehensive benefits. Single payer is the only road-tested plan that delivers these goals for the American people.
Thank you. I now yield 3.5 minutes to the gentleman from Wyoming, Mr. Thomas.
Thank you, Mr. Chairman. Let me restate again the question. That is, the U.S. should adopt a single-payer, Canadian-style health care system. That's the issue we're talking about. So let me open by stating what this debate is not about. We are not debating whether to have universal coverage and universal access. We agree all Americans should have the opportunity for coverage. The question is whether you achieve that with a Canadian-style system and with it the serious systemic problems that it would cause. We know the diagnosis for America's health care woes. It's the proposed cure of a single-payer system that we believe is a faulty treatment for the American people. We're debating the weaknesses and the failings of the Canadian system. And all of us know those failings exist. Rationing, high costs, technological shortages, substandard care, particularly in rural areas, huge tax burdens, lack of money committed to research. Three of us here were involved at the same time that are in the debate tonight, all visited Canada together, and we looked specifically at the single-player system. And the fact is that Americans under such a system would be left out, overtaxed and forced to accept a substandard health care. The bottom line is this. A socialized program is not the answer to Americans' health care problems. We know that by looking at Canada. We know that by looking at our own problems. Right now, we have 60 million people under single payer, 3 times as many as Canada in Medicare and Medicaid. They are a single-payer system which no one can hold up as a shining example of health care efficiency or quality. Indeed, if it weren't for the other system for the shifting of costs, that system would have collapsed. Patients, providers, and program administrators alike universally say these government programs have big problems and can't deliver health care as well. The inherent virtue of socialism is equal sharing of misery, and that's exactly, my friends, what we have, and that's what socialized medicine gives us. Philosophically, this country has a choice. Should U.S. adopt a single-payer system, socialism, or not? That's what we're debating here this evening, socialized medicine and bigger government, bigger taxes. None of these things are what Americans say they want, and the elected representatives, we must respect that. In yesterday's election, people proved that conclusively. Should we adopt a single-payer Canadian system? Absolutely not. We need an American-style system. One that fits Canada won't fit America. One that fits all sizes fails, especially when the country has 10 times as many population, 10 times as many people as does Canada. We're a different country. We have a different ethic. We do not need another country's bad idea of something so vital and so important to American people as their health care.
I now yield 3.5 minutes to the gentleman from Vermont, Mr. Sanders.
Thank you, Mr. Chairman. Let me begin by asking a simple question, and that is, do we believe, as the Canadians do, and as most industrialized nations do, that health care is a right of all people, or do we believe that quality health care should be a privilege of wealth? The more money you have, the better health care you receive. In other words, do we want to continue the current inequitable system which says that if you are rich, you can receive some of the best medical care in the world, but if you're working class or poor, tough luck. You, your kids, and your parents will not have the same opportunity for long life, for good health, as those people who have the money. That is really the heart of this debate. And let me be very clear about my point of view on this issue. I object strenuously to any health care system which says that the children of family farmers or factory workers in my state of Vermont who do not have a lot of money should get second-class care compared to those people who are wealthy. The only health care system which treats all citizens alike and which provides quality health care to all people, regardless of their income and without out-of-pocket expense, is the single-payer Canadian-style system, which is why I am fighting hard for that system in Vermont and for our nation. The Canadian single-payer system, which is administered at the provincial level, is not a perfect system. But in terms of access, in terms of simplicity, in terms of comprehensive care, in terms of cost containment, it works far better than our system does, and in terms of support from the people, is far more popular in their country than our non-system is in our country. Let me very briefly compare the two systems. Today in the United States, despite the fact that 37 million Americans, including 9.5 million children, have no health insurance, despite the fact that 50 million Americans are underinsured, despite the fact that senior citizens today pay out of pocket a higher percentage of their limited incomes on health care than they did before Medicare, despite the fact that we have one of the highest rates of infant mortality in the industrialized world, far higher than Canada, despite the fact that we have a lower lifespan than almost any other industrialized nation, including Canada. Despite all of that, the United States today spends 40% more per capita on health care than do our Canadian neighbors, who have a high-quality, comprehensive, universal health care system. Let me describe very briefly how, with a single-payer system, we can provide quality health care to every man, woman, and child in this country without spending 1 penny more than the $900 billion we are currently spending. First, by eliminating the 1,500 private insurance companies whose only function is to make money, not to provide health care, we can, according to the General Accounting Office, save an estimated 10% of our health care costs, some $90 billion. Under single payer, everybody has the same card, everybody goes to the doctor and hospital of their choice, and the bills are paid by a single public agency with a minimum of paperwork. The uncomplicated Canadian healthcare system costs 11% to administer compared to our cost of 24%. Every day in our country, more and more bureaucrats, insurance examiners, lawyers, and bill collectors are getting into the system, and they're costing us a fortune. There are enormous savings in the simplicity and universality of the Canadian plan that we should be enjoying as well. Further, single payer negotiates and limits the fees that doctors can charge. The result, medical procedures, whether it's an appendectomy or a coronary bypass, are significantly less expensive in Canada than they are in the United States. In fact, we are 72% higher in doctors' fees.
Expired.
Thank you, Mr. Chairman.
I now yield 3.5 minutes to the gentleman from Illinois, Mr. Hastert.
Thank you. Thank you, Madam Speaker. As a member of the Congress from the land of Lincoln, it's certainly an honor to participate in this first Lincoln-Douglas debate. We're here tonight to debate the issue of America adopting a Canadian-style government-run health care system. Adopting the Canadian health care system sounds attractive to Americans who are concerned about the skyrocketing costs and the millions of Americans who lack insurance. The Canadian model appears to solve both these problems. Everyone is covered and services are free. It sounds great. But as H.L. Mencken would say, there's always an easy solution to every human problem. And it is neat, plausible, and wrong. The same is true with the Canadian model. Briefly, to describe the Canadian system, it's a universal, tax-financed health insurance system. All Canadians have access without change and without charge to physician services. All residents must be covered and enrolled, and all plans are administered and operated by the provincial government. The flaw with this first approach fall into two categories. First, the Canadian system has no mechanism to control cost. Since all services are free, consumers have no reason to prudently purchase services. And since all hospitals are given a set budget, regardless of the quality of care, there's no incentive for them to adopt innovative and cost-effective and efficient improvements. The second flaw is that politicians and bureaucrats will decide how much health care is delivered, not patients and doctors. All we need to do is to look at Canada to see what the problems these structural flaws cause. Proponents of a single-payer system will say that such a system controls costs more effectively. The facts tell another story. As the first paragraph, or this first graph shows, from 1967 to 1987, real per capita health care spending actually increased faster in Canada than in the United States. Canadian fans also point to the statistic that Canada spends less of its GNP on health care than the U.S. But comparing these two fractions is like comparing apples to oranges. When talking about Canadian expenditures, the number doesn't include capital spending and R&D costs to the same extent the U.S. number does. Nor does it include expenses for dental care, prescriptions, ambulance services, private hospital rooms, and eyeglasses. It doesn't take into account the fact that the U.S. population is slightly older, nor that the U.S. has a much higher violent crime rate, heavier illegal drug use, and a greater incidence of AIDS than Canada. National health care advocates always talk about the huge administrative savings that would be realized if the government would take over our health care system. While a single set of rules, forms, and billing policies would save some money, the savings would not be enough to pay for the system. It's important to realize that the Canadian data used in comparison did not include many indirect costs associated with the system, such as facilities and equipment. In addition, roughly half the provider administrative costs in the United States are attributed to functions that would be largely unaffected by changing reimbursement methods. These include peer review organizations and federal quality control regulations. It's highly unlikely that these programs and their costs would disappear. Also, the litigious nature of American society also contributes to higher overhead costs. Health care providers must spend large amounts of money on documentation, risk management, quality assurance, legal fees, and medical liability premiums. The second set of problems stem from the efficient of having the government decide how all the money is spent. Health care is too complex and too sensitive to local needs for Washington to have all the answers. The Canadian system relies on government controls such as caps of expenditures, limits on high-tech equipment, and on physician supply. This has led to artificial shortages of critical personnel and equipment.
Gentlemen, we now move on to that portion of our debate where we do cross-examination. Again, following the agreed-upon format, participants have 30 seconds to ask a question of a specific opposing member. That member then has time for a 2-minute answer, to be followed by a 30-second rebuttal by the original questioner. I now yield 30 seconds to the gentleman from Washington to ask a question of the gentleman from Illinois.
Thank you, Mr. Speaker. Congressman Hastert, we have a number of other plans, health plans have been offered, including one that you yourself have proposed. They only promise universal access, not universal coverage. Only one plan, the single-payer plan, offers universal coverage. Now, window shopping is one thing, but the ability to buy is another. How will your approach assure that people will be able to actually afford health insurance? Our plan provides it. It provides a way to finance it. I would like to hear you say how you're going to cover everybody and make it possible for people to buy it.
We think it's important that people have universal access to health care insurance. And what we do is we allow, first of all, we focus on who doesn't have health care insurance basically in this country. They're small business people, they're farmers, they're barbers, beauticians, proprietors of their own business, partnerships. They're also people who work for small businesses. So our approach is to focus on people who don't have health insurance. What we do is to allow those folks to pool into huge groups, to guarantee them by the pooling to give them access to insurance, give them portability of health care to move from job to job. We also allow them then also for pre-existing conditions to reinsure in reinsurance pools. That's how you do it in liability insurance today. And also then we guarantee that they get the same breaks that any other American business would get. That's the ability to buy insurance at low cost. And incidentally, that's why those people can't buy insurance today. It's too expensive. When they go to the market with 1 or 2 or 4 people, they pay 1.5 to 4 times the cost that big business pays for insurance for their employees. Give people the break, give them low-cost insurance, and give them tax deductibility when they buy that insurance. That's something they don't have today. For people at 100% of poverty, we redirect DISH money. So that instead of people getting health care, such as my state of Illinois, it costs $15,000 for a family of 5 to get health care in the emergency room. Those people can get on board with a primary care policy, much less the cost, between $3,500 and $3,600. At people at 200% of poverty, we give them the ability to buy into these programs. That's a family of 4 earning $28,000. You give them the ability to take care of themselves. We have a basic premise that we believe Americans want to do the right thing. If they have the opportunity to buy good, low-cost insurance with portability, without prohibitions of pre-existing conditions, and get tax deductibility, they'll do the right thing and buy it.
Gentleman's time has expired. Now yield 30 seconds to the gentleman from Washington for a rebuttal.
If I understand your answer, you've adopted the President's proposal of creating a bureaucracy to pool small purchasers called the Health Alliance at unknown costs. It's unusual that you would suggest that we ought to create more bureaucracy. The second thing you come up with is you're going to subsidize people under 100% of poverty, which means you're going to have to set up some kind of welfare system by which you're going to give people the money if they need it. That's creating a second bureaucracy, which in my opinion is totally wasteful. The single-payer system says we subsidize everybody in the same pot. Everybody puts in, people take out what they need. You create bureaucracy to solve it. That is not an American way. It's not an efficient way.
I now yield 2 minutes, or 30 seconds, to the gentleman from Wyoming to ask the question of the gentleman of Vermont.
Chairman, let me preface my question with this chart, which shows the waiting time in the various provinces for the various procedures in Canada. It is true. Yes, it is. And my question is, Mr. Sanders, in Ontario, patients wait up to a year for eye surgery, 6 months for a CAT scan. Global budgets result in rationed care and result in substandard care. Who will be responsible for the woman who waits months for a biopsy after a mammogram while the tumor grows?
Now you have 2 minutes to the gentleman from Vermont for his answer.
Mr. Thomas, if I didn't know you better, I would think you'd be giving me the line of the insurance companies and trying to disparage the Canadian health care system. As you know, there is a multi-million-dollar effort right now to disparage, to create a whole lot of fantasy about what is going on in Canada. When we talk about rationing and we talk about waiting periods, let's compare what goes on in Canada to what goes on in the United States. In Canada, anybody can go in, rich or poor alike, to any doctor or any hospital that they want. In the United States, when we talk about waiting periods, what about the tens of millions of people who cannot afford to go to the doctor, who cannot afford to go to the hospital? Doctors in Vermont and all over this country are seeing patients today far sicker than they were 10 years ago because people cannot afford to go to the doctor and the hospital. In terms of the waiting period, so-called waiting periods in Canada, a lot of that, most of that stuff is absolute malarkey. 99% of the time, there are no waiting periods. In fact, in terms of women's opportunity to get help for breast cancer, they move faster in British Columbia than they do in the state of Washington. What you're hearing in the idea that people in droves are leaving Canada to come to the United States because of the waiting periods there is also utter nonsense. Most of the people from Canada who get treatment in the United States get treatment because they're ill in the United States. And I should also inform you that in the state of Vermont and in northern states, there are people who go over the border to Canada because of the reasonableness of the cost of their health care. The southern part of our country, there are Americans who go to Texas. But I would argue that in terms of the need for basic health care costs, basic health care, there are no significant waiting periods in Canada, and it is not worse than it is in the United States.
And now yield 30 seconds to the gentleman.
Mr. Sanders, you and I were there. We heard the doctors. We heard the report. Here's the report. I can give you the citation. Furthermore, your partner that comes from Washington State, please tell me if that's true, why British Columbia contracted Washington to perform 200 cardiacs. And so it is a fact that there's waiting. It is a fact that that's the way you ration. It is a fact that that's the result of global budgeting. There's no other alternative. That's the way it is. It is a fact that there hasn't been more money put in by the federal government. They've frozen it at 89 in 1989, and therefore there is rationing, and it can't really be argued.
Thank you. I now yield 30 seconds to the gentleman from Vermont to ask a question of the gentleman from Illinois.
Mr. Hastert, I would like to ask you, if you like, a philosophical question. Under the Canadian single-payer system, all people, the richest and the poorest, have equal access to the health care that they need, all of the health care that they need. My question to you is, do you agree that health care should be a right of all Americans, regardless of their income, and that the quality and availability of health care should not be dependent upon the income of the individual or the family?
Now I yield 2 minutes to the gentleman from Illinois for a response.
I think all Americans agree that all Americans should have a right to health care. They should have the right to be able to get health care insurance to cover themselves and their family. But one of the problems that we see in the Canadian system, and you were there and visited, and the various bureaus that we went, that even though the Canadians systematically have a right to health care, they pay a 39 to 59% marginal income tax in Ontario specifically. They pay a 15% value-added tax in Ontario, plus employers pay a $700 to $800 employee checkoff per employee. They brought in Ontario, because I was specifically interested in its comparison to Illinois, 10 million people in Ontario, 11.5 million people in Illinois, and the numbers were they spent $1,750 per person. $17.5 billion on health care spent in fiscal year 1991, right here in the Ontario Provincial Handbook, and they brought in the revenue handbook, $7.5 billion in Ontario in fiscal year 1991. The real problem is the revenue flow doesn't match the promises. That's why there's rationing. That's why there's the charade in Canada that we talk about of equal health care, that there isn't health care, because people can't get it. It's not there. They close down the MRIs at 6 o'clock. People have to go someplace else. They have to wait in line. And that's the problem. Here are the facts, Mr. Sanders, the facts that we saw and got from the officials in Canada. The revenue for this program doesn't match the outflow. And it'd be the same when you lay it on the 270 million people in the United States of America.
Now yield 30 seconds to the gentleman from Vermont for his rebuttal.
You didn't answer the question, Mr. Hastert, and therefore I gather that what you are saying is that you believe there should be a health care system in which if you have the money, you can go to the best doctors and hospitals in the world, but if you don't, your kids will die at a younger age, your parents will die at a younger age, and I gather that's the system you defend. In terms of taxes in Canada, the fact of the matter is, when you add taxes in Canada, which are slightly higher than in the United States, to the cost of private health insurance, which is much higher in the United States than it is in Canada, guess what? Both costs come out about equally. The Canadians do not have to pay very much for private insurance because they have a national health care system which provides all the care that they need.
I now yield 30 seconds to the gentleman from Illinois to ask a question of the gentleman from Vermont.
Gentlemen from Vermont, the single-payer advocates argue that such a system is more effective at controlling costs. While I agree that having one form would save money, we don't need a government takeover of the system to require only one form, electronic billing, and other reforms to lower administrative costs. However, the statistics of what happened in Canada clearly demonstrate that they haven't been able to effectively control costs. Could you explain what is the cost containment mechanism in the single-payer approach?
Delighted to do it.
2 minutes to the gentleman from Vermont.
Thank you. Delighted to do it. As the GAO told us, by getting rid of all of the bureaucracy of 1,500 private insurance companies billing, advertising, paying corporate executives huge salaries, we could save $90 billion right off the top. Number two, by negotiating doctors' fees, which in the United States are 70% higher than they are in Canada, we could save tens of billions of dollars. Number three, single payer enables us to negotiate with the pharmaceutical companies, which is why pharmaceuticals in Canada are 62% of the cost that they are in the United States. They don't allow their drug companies to rip their people off. Number four, by providing access to all people, people don't have to wait till they're very sick and end up with significant health care expenses in the hospital. So the savings are there, and that is why, Mr. Hastert, in the United States today, we spend 40% more per capita than they do in Canada.
Now yield 30 seconds to the gentleman from Illinois, Mr. Hastert.
Well, it's too bad that you weren't at the GAO hearing the other day when General Boehner took the stand and basically admitted that the GAO healthcare study that you've liberally quoted was flawed. They didn't add in everything, they didn't subtract everything, and the $90 billion of healthcare savings in Canada just doesn't exist. So, you know, we need to go back and take a look at what your basic premise is. Philosophically, we need the free market to develop competition. Competition among those healthcare providers holds down cost. And we need to make sure that that exists. The GAO...
Gentleman's time has expired. I now yield 30 seconds to the gentleman from Vermont, Mr. Sanders, to ask a question of the gentleman from Wyoming, Mr. Thomas.
Okay. Mr. Thomas, a variety of polls have shown that the Canadian people and their physicians, despite some of your rhetoric, feel very positively and very proud of their system, while polls in this country show widespread dissatisfaction among the public and our physicians with our health care system. The Liberal Party of Canada, as you know, recently won a landslide victory there last week, fully supporting, during their campaign, their health care system and rejecting user fees completely. One poll showed that 3% of Canadians wanted to go back to the good old American system that they used to have. My question is, given that reality, doesn't that suggest to you that we can learn from their system, that their system is working well, is supported by their people, and that there's much of their system that we can adopt here?
Now yields 2 minutes to the gentleman from Wyoming, Mr. Thomas.
Mr. Sanders, I do believe that there are some things that we can learn from. Certainly that would be true, I think, of each of the systems throughout the world. There are things that we could learn. I think there is advantage in their system in terms of administrative costs. But I have to say again that this is a different country. This is a different ethic. This is a different kind of an economy. This is a private enterprise economy. We're not as accustomed to having as high taxes and having government provide as many services. We're not accustomed to having 15% sales tax as they had in the province where we were, 50% income tax, in order to fund a government service that they have become accustomed to. That's the kind of thing they're used to. They're sort of used to using the United States as a safety valve. Where do we go when we don't have services? To Mexico? I don't think so. They've used this country as a support for that kind of a system. So of course it makes it somewhat better. My point, I believe, is that we're talking here about implementing and implanting on this country a so-called Canadian system that has been developed over 20 years there, is now beginning to run into serious financial problems. As you know, they have frozen the payments into these hospitals at the 89 level, which makes it more difficult under global processes. And so I just object to the notion that somehow, because they are somewhat satisfied or even very satisfied with that system, that would cause us, who are accustomed to much more technology, much more breakthrough in new techniques, and they readily admitted they look to the United States for all new techniques. And by the way, their costs don't show any of these kinds of research costs that we have here, and I hope continue to. So I think to say they're happy with it, we should be happy with it, is simply not a comparison that's valid.
I now yield 30 seconds to the gentleman from Vermont, Mr. Sanders, for his rebuttal.
Thank you. My point is that the Canadian people who have experienced their system for 20 years are overwhelmingly supportive of it as are their political leaders. On the other hand, in our system, physicians and ordinary people are grossly dissatisfied, by and large, with what's going on here. It seems to me that we can learn a great deal about what they are doing there if, in fact, we have the courage to take on the insurance companies and the pharmaceutical companies who are dominating the debate about health care in this country. Thank you.
I now yield 30 seconds to the gentleman from Illinois to ask a question of the gentleman from the state of Washington. Mr.
To my good friend from Washington, in a roll call article dated October 18, 1993, you stated that the Canadian-style health care system is not a government-run system. Government serves only as the single financing mechanism. While it's true that the Canadian hospitals are not government agencies and doctors are not government employees per se, having the government determine how much money can be spent by each hospital, the income level of each doctor, and whether or not a hospital can buy a new piece of equipment essentially means that the government's deciding how much of health care is being delivered to its citizens. Don't you agree that this is a huge expansion of government authority?
Now yield 2 minutes to the gentleman from Washington.
The American system, if you want to use your logic, is an insurance company-run system. And what we are talking about in this country is whom shall we give the control to? Shall we give it to the insurance companies, or shall we give it to the government and the elected representatives to make the decisions for all the American people? Because what is at heart here is a decision about whether it is a right to have health insurance in this country, of citizenship or of your employment. And I believe that we should move, and I think those of us who support the single-payer system believe we should move to a citizen-based decision-making that is decided through the elected representatives in terms of how much money. But the fact is the Canadian system is not run by the government. The patient comes to the doctor that they select. They go to the hospital that they select. It is a decision by the doctor what he shall do. In this country, you have to call an 800 number. I'm a physician. I know. You have to call an 800 number if you want to leave a woman in the hospital an extra day after the birth of her child. You can't make that decision on your own unless an insurance company gives you that option. But in Canada, the physician can make that decision on the behalf of his patient. And I believe that that's kind of system we really want, where you do not have the government coming between the patient and the doctor. That doctor-patient relationship is not broken in Canada or Germany or Australia or any of the countries in the world where you have a single-payer system. And I believe that increasingly in this country, as we hand the control of our health care system to insurance companies, and people at the end of 800 numbers somewhere, some clerk, you are taking away the essence of what we know in American medicine is important, the doctor-patient relationship. For that reason, I think that the government is not intrusive. It simply provides the money to pay the bills.
I now yield 30 seconds to the gentleman from Illinois for his rebuttal.
Well, you and I have both been to Canada. You've seen the global budgets put on hospitals and the rationing and how hospitals get by using 70% of the beds for people who are chronically ill and 30% of the beds for people who are acutely ill. We've seen doctors' salaries set at $125,000, so when they reach that, they go to Florida in October. We know how that system works. It is a rationing system, and we do agree one thing. We have to change the insurance system in this country. We have to make insurance companies accountable. We can't let them prohibit or underwrite pre-existing conditions, and we have to give people good portability health care. And I think our other alternative, 3080, that you mentioned before, does allow people to do that. It's a common sense, pragmatic way to solve the problem.
We now move to the next segment of this debate. A member from each team will have an opportunity to address any points from the previous section and offer a rebuttal to the information provided by the other team. Each speaker will have 2 minutes. I now yield 2 minutes to the gentleman from Washington.
Mr. Speaker, it's been interesting here tonight for anybody watching this and listening to it to listen to the myths about a single-payer system. I want to take one myth because I have one specific one I know the answer to. I've heard this thrown around over and over again, and that is British Columbia contracted with Seattle for 200 heart operations because, quote, there was no technology in Canada and there was a long waiting list. It turned out that that was a myth. It took them over a year to find the 200 patients. What the real problem was that Canadians wanted to go to two specific doctors, and of course there was a line. And when asked whether they would rather go down to the United States and have it done immediately in a university hospital like the University of Washington, they said, no, we want to wait for Dr. X here in Vancouver. There's no documented waiting lists of people who have serious problems in Canada. We have waiting lists in this country. You can't just walk into any doctor's office on any given day and get a routine thing taken care of. You have to make an appointment. And that's what a waiting list is. And the Canadians have it and we have it. Now, as to the high costs, I frankly find this discussion almost unbelievable that people would say the Canadians can't control costs. The Canadians spend 40% less per capita than we do. Whatever you want to say about their system, you can't deny that they've controlled the costs. That's simply laughable because they have been able to do it. We started out in 1960 spending about the same amount per capita as the Canadians, and since 1980, we have gone to, or 1960, we've gone to 15% of our gross national product, whereas the Canadians are less than 10%. It is simply not true that they cannot control costs. Now, as to the question of whether they interfere between the doctor and the patient, I want to deal with that one again because I think it's absolutely crucial. Every Canadian has the right to choose whatever physician they want to go to, whatever hospital they want to go to. That is not true today, and it will not be true if these HMOs that people are going to be forced into on an economic basis occur.
I yield 2 minutes now to the gentleman from Wyoming, Mr. Thomas.
Thank you, Mr. Chairman. Let me just comment on the growth. Here's a chart that charts it clear back from '67. But you mentioned particularly that area in the 80s. It shows that the increase in real health care spending per capita in Canada had risen in 82 to 87, 4.4%. In this country, 4.1%. And it follows that pattern. So there has been growth, and it continues to be. You indicated that single payer is not a government program, but in your article, Mr. McDermott, you went on to say that the government collects the money, sets the benefits, determines the minimum benefits package, and certainly, of course, would regulate the state associations. It's naive to even suggest that the federal government is going to collect the money and pass it out to any entity without regulation. I think we struggle enough here with over-regulation to know that that is not the case. We're talking here about the Canadian plan. My friends have shifted over to the plans that are being talked about here. We're talking about the Canadian plan. We're talking about the cost of that and the taxes that would have to be raised. We're talking about the fact that if states financed it, as provinces do, it would take a 47% increase in taxes in states to do this kind of thing. There's pretty good evidence, I think, that there is no willingness on the part of this country to pay that kind of tax increase for a government-controlled health program. If there's anything that we have good evidence of is frustration in this country with government regulation and government involvement. So to suggest that a government-controlled health program for everyone in this country, whether they be Amish or some who don't want to be involved, and to say that that's what we ought to lay on everyone, it seems to me has just no support in the evidence of our experience.
Thank you. In the final segment of this debate, each participant will offer a 3-minute closing argument. Members will speak in the reverse order of their opening statements. I now yield 3 minutes to the gentleman from Illinois, Mr. Haspert.
Well, Americans know that we need to change what's wrong with our health care system. We must expand access and control costs. They're impatient for that change, and rightly so. They also want us to preserve the excellence and the choice that they have come to expect. And they don't want to see their health care costs go down, only to see their taxes go up. But if we've shown tonight in this debate, all the Canadian system can complain and claim is that everyone has access to the system. But you have to stop and ask yourself, what is the quality of the system? How long will I have to wait to get the test or procedure I need? How much more time and how much more will I have to pay in taxes? They promise that they'll be able to expand access to everyone, and no one will have to pay more. But remember what your mother told you, if it sounds too good to be true, it is. They cite government estimates and reports produced by the CBO and the GAO, but remember, the government has never correctly estimated the cost of its programs. That's why Congress keeps going back to hard-working Americans to ask them to pay more in taxes. This case is no different. Their sole cost containment mechanism is simply to have the government say we'll have lower costs next year and then forbid hospitals from getting the latest and best equipment. But is that how we want costs lowered? Fortunately, there are other options out there. If we want to control costs, we should target the key cost drivers. We should reform our malpractice system, which this plan doesn't even talk about, to eliminate the unnecessary procedures that are done simply to protect the provider if they're dragged into court. We should adopt a single insurance form and electronic billing so that administrative costs are lowered. We should tighten our fraud laws to eliminate this cost in our system. And we should reform our antitrust laws so that communities have the opportunity to coordinate the delivery of health care in their areas. No longer will each hospital have to buy the latest and often most expensive diagnostic tool. And if we really want some cost control, we ought to give the Americans a chance to get a Medisave, a medical IRA system, so that they can begin to have an action in cost. The problem with the third-party payer system that we have in this country today is that if you go to a doctor, it's always the government, or it's the insurance company, or it's your employer that's paying the bill. Americans ought to get involved in this practice when they can, and we ought to give them the ability to do that. The debate on health care reform has just begun. Whatever reforms we adopt, we should make sure that it controls spiraling costs and makes health insurance affordable. Most important, we should make sure reform leaves the patient in charge of the health care decisions, not the government. And that's a prescription for real change. Thank you very much.
I yield 3 minutes to the gentleman from Vermont.
Thank you, Mr. Chairman. Boy, do I wish we had more time. Just a few points. Yesterday's Washington Post, the cost of health care. Here's the chart. United States, highest in the world, $2,868. Canada, $1,915. Everybody understands that health care in the United States per capita is far higher than in Canada, despite the fact that they have universal coverage, comprehensive coverage for all of their people. You keep using the word taxes, taxes. Let's not fool the people. In Canada, taxes are a little bit higher. But guess what? They don't have to pay $2,500 per person for private health insurance. That comes out of their tax base. Add taxes, add health insurance together, it's about the same for both countries. Mr. Chairman, 60 years ago, Franklin Delano Roosevelt, as President of the United States, fought for national health care for all people. In 1948, Harry Truman campaigned for national health care for all people. How has it happened that the U.S. today, along with South Africa, remains the only industrialized nation on earth that does not have a national health care system guaranteeing health care to all people? And I'll tell you how it has happened. It has happened not because of a debate over health care. It's a debate over economics. It's a debate over the insurance companies, certain physicians, the pharmaceutical companies, the medical equipment suppliers who are making billions and billions of dollars off of human misery. It's all about Common Causes study, which tells us that the medical industrial PACs have spent $60 million over the last 10 years trying to influence this Congress not to pass a national health care system. It's about the CEO of Bristol Myers Squibb, a large pharmaceutical company who makes $13 million in income in 1991, while elderly people cannot afford the prescription drugs that they need. And the reason we don't have a national health care system is that the medical industrial complex is protecting the likes of Mr. Thomas First, the CEO of the Hospital Corporation of America, who last year earned, let me say it slowly, who last year earned $127 million in income running a hospital corporation at the same time as millions of Americans can't get into the hospital. That's an outrage. Poll after poll shows widespread support for the Canadian healthcare system among their physicians, among patients, among their political leaders. Poll after poll shows widespread bad feelings, widespread unhappiness with the system that we have here in the United States of America. Mr. Chairman, it is time the American people stood up and said, health care is a right of all people. Let's control health care costs. Let's do what the rest of the industrialized world does. Let us pass a single-payer national health care system. Thank you.
And now I yield 3 minutes to the gentleman from Wyoming.
Thank you, Mr. Chairman. Let me say first that I've enjoyed the opportunity to discuss this with my friends. I think this is a useful kind of a debate. I should also say to my friend Bernie Sanders, we don't agree on much of anything. Philosophically, on economics and on other things, we are very separated. I am not a socialist, and I don't believe in socialism. I believe in the capitalistic system. So I think you take a system that you have, which most people in this country find good for them, and we should fix those things that are broken. And it isn't necessary for us to uproot all of the things that have been done well. We need a program for Americans, a program that fits our needs. We have 240 million people. Canada has 27 million. Americans don't want socialized government-controlled medicine. We don't want a huge tax burden that's an impact on the economy. We don't want to turn our health problems into problems of unemployment. We need to examine carefully, I think, those things that need to be fixed. We need to fix them, and we need to move promptly to fix them. And I suggest to you that there are some things that we could do very quickly, and trying to change the whole system will not come quickly, and I think we will wonder why we didn't do the things that can be done. We today have talked, and our purpose was to examine the Canadian single-payer system. We've done that. It clearly appears not to have overwhelming support in this country. There's not overwhelming evidence that it would be good for this country. Even President Clinton rejects that payer program. More and more Americans are showing opposition to his plan as having too much government. Rationing, high costs, technology shortages, substandard care, particularly in rural areas, huge tax burdens. These are part of the evidence of a single-payer plan. The answer to today's question is quite clear. Not the Canadian system for America.
And now you have 3 minutes to the gentleman from Washington.
Thank you, Mr. Speaker. I, too, am grateful for the opportunity to participate today. I'm sorry that sometimes these debates, though, devolve into just throwing sort of slogans back and forth. And we talk about socialism and all these things to scare people. But I think if you look carefully at our healthcare system, we have had 45 years of uncontrolled free enterprise in this country. It's been very little. The problems have been there. The free enterprise system has simply failed to deal with it. And what we have now is a system that for many Americans is one paycheck away from having nothing. The single largest cause of personal bankruptcy in this country is because of the single fact that they do not have ability to pay their medical bills. Now, the question has been asked here, what is broken? What is broken is the financing system. And it is clear to us, and 89 members of the House have signed this bill, that the best financing system is one in which we reach out and capture the premiums that are now being paid to private insurance companies and place them in a government system, saving ourselves $70-some billion and covering everybody in this country. Our proposal, the GAO says that 90 to 95% of Americans would pay the same as or less than they are paying today. Now, you have to have universal coverage, because if you do not have universal coverage, you will never be able to get cost controls. As long as we have the freedom in this country and the openness that allows people to go into the hospital and receive care whether they have money or not, they will go in when they're sick. They will wait and go in when they're very sick. That cost is passed to people who are paying their premiums. That cost shifting cannot be stopped unless everybody in this country has health insurance and is paying their fair share. And we who support the single-payer system think everybody ought to pay their fair share. Now, the question then is, why should we go to the single-payer system? I hear some disparaging remarks about the CBO, but you know, they are sort of a hard-headed bunch. They said that if the single-payer system were in place today, we could save $350 billion over the next 5 years. Now, it seems to me unreasonable that conservative people would reject a system that has worked in every industrialized country in the world and provides high-quality care. As a physician, I wouldn't participate in putting together a program that did not deliver high-quality care. That's why 9 out of 10 Canadian physicians say they would keep their system. They would never opt for the American system because they can take care of patients, they can deliver the health care that's necessary, and they don't have to chase patients for bills or put people into bankruptcy. Now, from my standpoint, that kind of a system is the kind of system that I think we can adapt for Americans. I agree with those of you who say we can't bring Canada to the United States. Of course we can't. Their plan was developed in 1946 and has evolved over 40 years. What we are designing here is an American health security system. We will hand everyone a card, and everyone in this country will be able to get their health care no matter where they are, no matter how much money they have or who they are. The single-payer system is the way to go.
Well, this concludes tonight's debate, and I'd like to thank all of the participants that are here with us tonight, Mr. Thomas from Wyoming and Mr. Sanders from Vermont, and Mr. McDermott from Washington and Mr. Hastert from Illinois. Thank them for the excellent job that they've done. I'd also like to thank Representative Bernie Sanders and the Progressive Caucus, my colleagues in the Conservative Opportunity Society who have made tonight possible.
Thank you for doing a very fine job of moderating tonight, and we look forward to working with you in a cooperative way.
Thank you. I'd also like to thank the leadership on both sides of the aisle that have made this possible tonight and have worked well with us. There are more debates to come. We hope to do one in the next several weeks before we break, before Thanksgiving. But you can count on the fact that next year we'll be back, and we expect to do at least twice a month during 1994. Again, thank you and good night.